conmigo al baño? Vaya, sí. I always had to feel like this. ¿Qué puta tocar pizza? Prefiero comer Jimmy Dog. Subway. right? You have service with him?
Everyone who's speaking, they can sign the consent form. Top line says you don't have anything to, you don't have any conflict?
It's one paper. When we're done, do you want me to just take your gym bag or no? No, I'll take it. Oh, we're doing like the video again? Gotta be transmitted live. Here's Angela. Transmitted live, Justin. I'm not even phone. I did, super early.
Hey Angela, am I presenting initially, like,
Yeah, you're the first.
yes, like the actual presentation?
Yeah.
I didn't even look through the, can we sit down, because there's an idea on one of my slides.
No, I have it on my question.
Sorry?
So you're going first, and then I do my part, and then you do the details. And then it's Dr. It's the Land Rounds 2016 final. There's like 2 days or something.
That's what I'm saying. Did you get, Dr. Bob's class? I think the sign was Angela. Be looking at you the whole time, Raquel, up in that corner. Imagining you naked. Just kidding, in underwear.
I'm making faces.
Don't. I present everyone? Did you present everyone, Raquel?
I'm not even hungry.
I can't even eat, I'm so nervous.
I don't throw up. Maybe it's the
Dry runs. We're going to have a case today of hypotonic newborn infant, and our presenters are our residents, Jasmine Saavedra and Angela Chand, and our consultants today, Dr. Bach from genetics and Dr. Matt from pediatric neurology. So thank you.
Hi everyone, I'm Jasmine. We'll be presenting hypotonic newborn infant, as David just said. So the case presentation goes as follows. Baby girl was born at 37 weeks gestation via C-section, secondary to previous low transverse C-section to a 33-year-old G3P mother with history of uterine deficit, UTI, and her prenatal care was here at UIC, and it was essentially unremarkable. Her serologies were all negative. She was GBS positive, but she had C-section. Her blood type was A positive, but antibody negative. She denied any substance abuse, alcohol, or tobacco during her pregnancy. All of her prenatal ultrasounds were unremarkable with normal fetal anatomy. Birth history, rupture membrane was at delivery. There was no meconium, no breech position. At first, scores were 9 and 9. Birth weight was in the 34th percentile using the Fenton growth chart. Length was at the 65th percentile, and the circumference was in the 52nd percentile. The baby was breathing at room air, but noted to be weak and have a high-pitched cry. She was transferred to the newborn nursery for routine care. On physical exam, the remarkable findings in the head were that she had a prominent necrotic ridge. The eyes were essentially normal, no epicanthal folds. The nose was noted to have a short body and high bridge. The ears, they were posteriorly rotated and malformed bilaterally, and the right ear had a hypoplastic ear lobule and a thick helix. The left ear had a malformed helix. There was no tags or hits. Mouth had micrognathia and retrognathia. There's a picture that should be. And then the neck had extra skin at the nape. The cardiovascular exam was normal, no murmurs. The chest she had widely spaced nipples. Respiratory-wise, it was clear to auscultation. GI-wise, there was no hepatosplenomegaly. And on the extremities, she was noted to have hypoplastic toenails bilaterally, and they were thin and spoon-shaped. Neural, she was noted to have generalized hypotonia, upper extremity over lower extremity, a poor step reflex, scarf sign past midline, head lag without elbow flexion, and then the foot to ear test was almost at 90 degrees. On day of life 0, the baby was transferred to the NICU, secondary to persistent weakness and a high-pitched cry. She was also noted to have temperature instability, a weak suck reflex, and poor PO intake, and also she became hypoxic. So the treatment that was started in the NICU was NG feeds, IV fluids, and CPAP as she was desatting, and then a workup began. So they did a ClinChem, CBC, CRP, LFPs, thyroid studies, blood gas, and genetic studies. These were essentially the labs, which were essentially unremarkable. The CBC failed to show an elevated white count or an elevated IT ratio. The CRP was within her normal limits. The chemistry panel, all of the electrolytes were within normal limits. LFTs were unremarkable. The blood gas was when she was on CPAP was unremarkable. The newborn screen was sent. The thyroid studies weren't sent initially, but they were sent pretty within the first 4 days of life, and they were also within normal limits. The radiographs that were done was a retroperitoneal ultrasound to look for midline defects, which was unremarkable of both the kidneys and the bladder. A chest x-ray was sent given the respiratory distress. It showed a highly unusual gas pattern in the belly, but chest x-rays that were done thereafter were normal. A neonatal head ultrasound was done. It was limited, but showed a suspicious tiny grade 1 left IVH, which led us to do an MRI brain without IV contrast, which failed to show any intraventricular hemorrhages, periventricular leukomalacia, or any germinal matrix hemorrhage. And the myelination pattern was appropriate for her age. The consults we got was genetics. They sent genetic studies. Neurology workup included an MRI and an EEG. The EEG was mildly abnormal due to excess discontinuity for the age, which suggested mild bilateral cerebral dysfunction. It wasn't specific to an etiology, and there was some clinical correlation that needed to be done. Ophthalmology, the eye exam was normal.
Hi, I'm Angela. I'll be discussing the differential diagnosis of a newborn with hypotonia without sepsis trauma and major intracranial hemorrhage. So when presented with a newborn with hypotonia, one of the first steps is to determine whether the hypotonia is more central or peripheral in origin. These are features of cerebral or central hypotonia. The patient has some of these features, including dysmorphic features and adducted thumbs. Motor unit disorders or peripheral hypotonia have some of these features. The patient did not have most of these, so we'll not be discussing these. These are some causes of cerebral hypotonia. This includes chromosomal disorders, other genetic defects, chronic non-progressive encephalopathy. Cerebral malformation was ruled out on our MRI for this patient. There are paroxysmal disorders and other metabolic defects, and benign congenital hypotonia. So at the top of our differential in terms of genetic abnormalities leading to hypotonia in a newborn is Prader-Willi syndrome. There's also trisomy 21, MECP2 related disorders, which includes the classic Rett syndrome. And other two diagnoses are familial dysautonomia and musculocerebral disorders. So Prader-Willi syndrome is a syndrome that is characterized by hypotonia, hypogonadism, cognitive impairment. There are some characteristic facial features. Infants with Prader-Willi syndrome will have hypotonia and feeding difficulty until 8 to 11 months of age. Then this is replaced by relatively normal muscle tone and insatiable hunger, leading to obesity. Trisomy 21. So infants with trisomy 21, one of the first signs may be hypotonia, as well as these characteristic physical features. MECP2 related disorders includes the classic Rett syndrome. There are also other disorders within this group, including the variant Rett syndrome, which presents with neonatal hypotonia, and MECP2 duplication disorder, which also presents with hypotonia. There is associated cognitive impairment and recurrent respiratory infections in this disorder. There are some characteristic facial features. Familial dysautonomia is also known as Riley-Day syndrome. This is more commonly seen in Ashkenazi Jewish populations. This is characterized by temperature instability, labile blood pressures. You may notice absent funniform papillae of the tongue. Infants may not have overflowed tears with emotional crying. Cerebral renal disorders, also known as Lowe syndrome. This is characterized by cataracts, half of affected boys have glaucoma. There's proximal renal tubular dysfunction and slowly progressive chronic renal failure, as well as intellectual impairment. Paroxysmal disorders. So within this spectrum, there are two that I'll mention, Zellweger syndrome and neonatal adrenal leukodystrophy. These are some of the common characteristics of disorders within the spectrum. So there's severe hypotonia, oculocorticosis, and facial abnormalities such as the pear-shaped head, micrognathia. There may also be biliary cirrhosis, polycystic kidneys, retinal degeneration, and cerebral malformations. These are a few other metabolic defects that may present as neonatal hypotonia. Benign congenital hypotonia is a controversial diagnosis. There is some controversy whether it is a real diagnosis. These patients later are found to develop normal tone. Intellectual disability frequently becomes apparent later in life.
the genetic test took a little bit longer to come back. The chromosomal analysis came back fairly quickly. It was normal, and we were looking for Turner syndrome, which it ruled out. The microarray analysis was sent next to look for microdeletions, which showed a normal female microarray, but it had one long contiguous stretch of homozygosity detected by SNP analysis on distal chromosome 15. Because of that, those results, we then sent methylation-sensitive PCR to rule out Angelman versus Prader-Willi syndrome. And when that came back, it was significant for Prader-Willi syndrome. The hospital course, once the patient was diagnosed, she was transferred to the Peds floor for observation of the NG feeds and need for a G-tube. She was hospitalized for a total of 2 weeks on the pediatric floor. An upper GI was done and it was normal, and so a G-tube was placed as patient continued to have a poor suck reflex and poor fetal intake. She was discharged home in a stable condition and had follow-ups with genetics, ophthalmology, neurology, and endocrinology.
All right, so I was tasked with the task of how to evaluate a patient with hypotonia. So, I just wanted to give you sort of a neurologic perspective, or sort of what we as neurologists do when we start taking care of these kids with hypotonia. There are a lot of diagnostic challenges. They can be a sign of mostly serious, but sometimes benign conditions, and the differential is exhaustive. And I'm not going to go through the complete differential. But when a neurologist sees a patient with hypotonia, we sort of divide it up into sort of the different aspects of the nervous system. So there's the central nervous system, so that's where we'll see genetic or chromosomal disorders like Prader-Willi syndrome, metabolic diseases that can cause encephalopathy, spinal cord injury, so like a lot of traction on the cervical spine can sometimes cause injury to the spinal cord at birth and causes hypotonic picture, cerebral dysgenesis, and of course the most common one would be hypoxic ischemic encephalopathy. Then we sort of go out to the peripheral nerves, so then there's congenital hypomyelinating neuropathies, familial dysautonomia, infantile neuroaxonal degeneration, and sort of part of that goes along with the motor neurons, so that's sort of the things in the spinal muscular atrophy family, or disorders of the motor unit. And then there's neuromuscular junction disorders, so congenital and myasthenic syndromes, which are genetic, as well as the transient myasthenia gravis, which is usually babies born to mother with the autoimmune form of myasthenia. Infantile botulism, that usually doesn't present in the neonatal period, that presents after they go home, sometimes several weeks later. And then there's a sort of muscle problems, so the muscular dystrophies, the metabolic myopathies, the central cord disease, and other fiber-related myopathies, and then other sort of congenital myopathies are lumped into that. So that's how we sort of break it down. And each sort of group of conditions has specific clinical features, which is what we specifically look for on our clinical exam. So when we're talking about hypotonia, there's central versus peripheral hypotonia. So peripheral causes include anything in the motor unit, anterior horn cell, peripheral nerve, neuromuscular junction in the muscle. Central causes account for most of it, so most of the time when we're called to the NICU, it's because they have some sort of central cause, and 60 to 80% of all hypotonia is central. And then there are some overlap of the clinical manifestations, but there's some sort of distinguishing features. So central hypotonia, any sort of cerebral insult, so hypoxic ischemic encephalopathy, intracranial hemorrhages, congenital brain malformations, chromosomal disorders, peroxisomal disorders, which Angela talked about, other genetic problems, neurometabolic disorders, and then drug effects, obviously. So if mom was using benzodiazepines or opiates or things like that, then babies can be born looking like they're depressed and have sort of the drug effects still on board. And then there's that term benign congenital hypotonia, which is kind of a diagnosis of exclusion. You give that to them as they grow up and their tone improves. And so we usually don't diagnose that specifically in the neonatal period. So disorders of the motor unit include anterior horn cell, peripheral nerve, neuromuscular junction, and muscle. Anterior horn cell disorders include the infantile spinal muscular atrophy. Traumatic myelopathies are sort of found in that sort of category because, again, any sort of traumatic or hypoxemic myelopathy injures the anterior horn cells in the spinal cord, and then infantile neural axonal degeneration. There are the neuropathies, the congenital hypomyelinating neuropathy, giant axonal neuropathy, CMT, which doesn't really present in that early in infancy, except rarely, and then Dejerine-Soda syndrome. The neuromuscular junction disorders, so myasthenia gravis or transient acquired neonatal myasthenia, which we sometimes see, and then the congenital myasthenic syndromes, which are significantly more rare. Infantile botulism, magnesium toxicity, so a mother who got magnesium for eclampsia or preeclampsia, sometimes are born with floppy babies, and it takes a few days for it to clear, and they perk up and they get better. And then there's aminoglycoside toxicity, which can also do this, but again, that's pretty uncommon. The myopathies, again, these are disorders of the actual muscle itself, and there are many more than these 6 that I've listed, but just sort of to give you an idea, as well as then the muscular dystrophies, which present similarly to the myopathies. The only difference between muscular dystrophies and myopathies is dystrophies tend to be more of a destructive processes, and so they often have elevated CK associated with it, whereas myopathies are more static typically. So, and then there's the metabolic and multi-system disease, so the phosphofructokinase deficiency, phosphorylase deficiency, neonatal adrenal leukodystrophy, things that our genetics colleagues know more about. So, like I said, the most common cause of hypotonia is hypoxic ischemic encephalopathy, which will then lead to cerebral palsy in the young infant. But usually this involves initial hypotonia, so in the sort of immediate perinatal period, there's hypotonia, and the appearance of weakness. And as these babies age, sometimes, even within the first few days of life, it progresses to hypotonia, sort of more spasticity. The most common neuromuscular causes are actually still pretty rare, so the congenital myopathies, the myotonic dystrophies, and then spinal muscular atrophy. And then disorders with both central and peripheral causes, like Zellweger syndrome, sort of show a mixed picture. So what do we do when we see this baby? So a lot of times our history is very important in neurology. It's, even though the baby's only a few hours old, that's no different here. So you want to identify the cause and the timing of onset. You want to identify maternal exposures. You want to have information on fetal movement in utero. A lot of times if it's the second or third pregnancy, mom can compare it to previous pregnancies and say, this baby didn't really move as much as the other babies did. You want to look at what the fetal presentation was, because a lot of babies who are hypotonic in utero, they can be breech or malpositioned, and then the amount of amniotic fluid can also sometimes be helpful. Low APGAR scores can suggest floppiness from some sort of in utero situation, either something that was congenital or an event. And again, breech delivery can be helpful to say, if this baby didn't move enough to get themselves in position, maybe there was something going on the whole time. So a term infant who is born healthy but normal and develops floppiness after 12 to 24 hours, you want to sort of think about inborn errors of metabolism. Infants suffering central injury usually develop over the course of a couple of days, increased tone and increased deep tendon reflexes. So again, as you're following these kids, you can sort of try and piece together what's going on, because most of the time you don't know right at the get-go. And then central congenital hypotonia usually doesn't worsen with time, but sometimes becomes a little bit more readily apparent as the baby doesn't do what we expect them to do. Family history is also critical, so any family history of developmental delay might suggest chromosomal abnormalities. Anybody else in the family with delayed motor milestones, premature death, also those are things that may suggest sort of going down different paths for working that baby up. And then, of course, our exam. So when you're looking at a baby who's hypotonic, they pretty much all look the same, whether they're hypotonic from a central cause or peripheral cause. They're usually not really moving a whole lot. Their arms and legs are usually sort of frog-legged and sort of just not like the flexed tone that we're used to seeing. This is just a picture of a baby that you're sort of picking up, and you're cradling the shoulder girdle and the neck, and the arms are sort of flopping back, and the legs don't really look like they're doing a whole lot. Feeding history, again, in the first day or so of life can also sort of help us delineate what we're doing or what we think might be going on. So any sort of feeding fatigability, so they start out strong and they tucker out after a few minutes, might suggest a neuromuscular disjunction disorder. Just persistently poor feeding, so not initiating suck and swallow or things like that might suggest something more centrally. So you want to sort of get those patterns usually from the nurses at the bedside. Our general examination, again, we look at the baby for any signs of, any dysmorphisms or malformations or things like that. Babies who are lying motionless, for several days and aren't really turning their heads will often get a flattening of their occiput. Again, that's hard to say or tell in the neonatal period where they have a lot of molding. Sometimes you'll see hip subluxation or orthogryposis that suggests that there wasn't normal tone in utero either. Orthogryposis can vary in severity from clubfoot, which is the most common manifestation, to symmetrical flexion joint deformities in all limbs. And usually that's the result of just the baby being compressed against the uterine wall and not really moving around. And so then they get these fixed deformities and joint contractures. And usually newborns with orthogryposis who require any sort of respiratory assistance don't really survive extubation unless the underlying disorder is a transient myasthenic syndrome, which frequently improves over time. The quality of the cry is something we also pay attention to. So if there's a high-pitched or unusual sounding cry, that suggests there's something going on in the CNS. A normal sounding cry that's just sort of low volume or weak sounding may suggest some diaphragmatic weakness, so something a little bit more peripheral. A fatigable cry, so a cry that starts out really robust and then after a few moments sort of just tuckers out and suggests more of a congenital myasthenic syndrome. So, and again, then we physically examine the patient, right? So the most important thing we do is a traction response. That's not present in somebody less than 33 weeks gestation. So when you're evaluating the newborn, you grab them by the arms and you pull them up. And most newborns will have a little bit of head lag, but they should make an effort. So there should be some flexing at the elbow. If they don't really make any effort and are just sort of letting their head flop backwards, that is one of the strongest signs that we use to determine whether or not the baby's hypotonic. By 1 month, a normal infant will pretty much lift their head immediately as you pull them up, and they'll maintain elbow flexion and sort of pull themselves up with the trunk. Ventral suspension, so this is when we lift the baby up by their armpits. So if you're not sure, you should grasp the thorax. But if you lift them, a normal baby, if you lift them up by their armpits, they should have enough truncal tone in these sort of proximal shoulder girdle muscles to be able to support themselves. A baby with hypotonia is just going to sort of flop and slide right through. So don't lift them up over the bed too far. The muscles of the shoulders, again, like I said, have sufficient strength to be able to maintain that posture even in a brand newborn infant for several seconds. If a baby can't sort of keep themselves up and their head kind of falls forward and flops down, then that suggests that there's some more weakness. So other pertinent findings, we always check sort of tone, passive range of motion. So if there's decreased resistance to flexion and extension of the extremities, then that is more axial, appendicular hypotonia. If there's exaggerated hip abduction or ankle dorsiflexion, there's oral motor dysfunction, there's poor respiratory effort, gastroesophageal reflux is often seen in these children with hypotonia, so it's something that could be a clue. And then you also want to look at the distribution of weaknesses. The face spared, or the trunk or extremities spared, that can sometimes be helpful. Deep tendon reflexes. So in central causes, they're usually hyperactive. The exception to that is spinal cord injury. You can sometimes have spinal shock, which will make the deep tendon reflexes go away temporarily. But in central causes, for the most part, they're hyperactive or at least normal. You may have clonus or other primitive reflexes that we expect in newborns. In peripheral disorders, you can have normal reflexes, but more often than not, you'll see decreased or absent deep tendon reflexes. So that's sort of just a summary of all of those things that I went over, which can sort of help you differentiate what type of disorder you have. So again, clues to what we look for: dysmorphic features, depressed level of consciousness or lethargy, abnormal eye movements. Early onset seizures is a pretty strong central clue that this is something going on in the brain. Apnea, exaggerated or irregular breathing patterns, axial weakness, normal strength. So again, the baby seems like when they're moving, but you actually have low resting muscle tone. That is a sign of central hypotonia. Scissoring on vertical suspension, so that's where the legs kind of cross like that, tells you it's most likely to be central. Fisting of the hands and cortical thumbs also suggests central. And like I said, hyperactive normal reflexes. And then malformations of other organs tells us that there's probably something genetic or something going on. So when we're talking about central hypotonia, we look for HIE, teratogens, metabolic disorders. Most syndromes don't actually evolve to hyperreflexia and hypertonia, but some of these brain injury causes can, and they develop at upper weeks to months. Clues to anterior horn cell disorders. So this is a picture of a baby who's hypotonic and has generalized weakness and absent reflexes and feeding difficulties. So everything you would expect. But if you look at that baby's face, they're awake, they're alert. They look like there's somebody home. There's stuff going in. So this is the classic infantile form of spinal muscular atrophy. In SMA, if you look at the tongue, they'll often have little flickering types of movements. They will sometimes, if they're old enough to reach for things, have some sort of intention tremor. But again, these babies with peripheral hypotonia they'll look at you and they'll know what's going on. So when you have an alert baby who appropriately seems to respond to their surroundings, but really just doesn't seem like they can move, then that's when you think of these more peripheral processes. So when we're trying to differentiate anterior horn cell disorders versus things like myasthenia or neuromuscular junction disorders, so anterior horn cell disorders usually spare extraocular muscles, so they'll have full eye range of motion and normal eye opening and things like that, whereas children with neuromuscular junction disorders may have droopy eyes or sort of more facial and bulbar weakness that we sometimes see. Again, what the other things that we look at: hepatosplenomegaly, renal cysts, high forehead, white fontanelles, any sort of dystrophic features that can sort of pinpoint you somewhere. Congenital cataracts that might suggest Lowe syndrome, some abnormal odor which might suggest a metabolic disorder, hypopigmentation, undescended testes, viscous oral secretions like we see in Prader-Willi syndrome. So those are things, again, that we sort of help clue us out. Any questions?
Okay, so my name is Gifty Bhatt. I'm one of the new genetics attendings here. So after that really informative hypotonia in infant lesson, I feel like I should have taken some notes too. I'm going to move on to the diagnosis that we made with this infant, which was Prader-Willi syndrome. So Prader-Willi syndrome, it's not necessarily a new condition. It's one of those rather common genetic syndromes in the world of rare diseases. The first time it ever came in literature was all the way back in the 1680s when Juan Carino de Miranda had made this painting of a girl who presumably had Prader-Willi syndrome. Further, we come down to 1956 is when first time a group of 3 Swiss doctors defined and illustrated and described the full presentation of this syndrome, and their names were Andrea Prader, Heinrich Willi, and Alexis Laupert, hence the name Prader-Willi-Laupert syndrome in the beginning. Somehow we forgot about Dr. Laupert since then. So between 1980s to 1990s, several independent groups identified the etiology of Prader-Willi, which was, of course, the deletion syndrome, but also the underlying cause, the lack of expression of paternally inherited genes in this specific region of 15q11.2 to q13. 2000 was a wonderful year for Prader-Willi syndrome because finally we had FDA approval for growth hormone therapy. So a little bit of background, or just like a definition for Prader-Willi syndrome. We like to describe this as a syndrome of diminished fetal activity. So, like we alluded in the previous slides, it starts way back when the fetus is still in utero. And often some moms will talk about diminished fetal movements, or oftentimes there'll be just a breech presentation. Further on in neonatal period, you will notice hypotonia, hence the whole talk today. And later on, obesity, intellectual disability, short stature, hypogonadotropic hypogonadism, and the characteristic facial features with small hands and feet. The prevalence is about 1 in 10,000 to 1 in 15,000 live births annually. So not as common as Down syndrome, but still rather common in the rare disease world. Males and females are all affected equally at all races. So looking at the natural history of Prader-Willi syndrome before the start of growth hormone therapy, this is what an infant or a neonate would look like. He would be hypotonic. You might notice some cryptorchidism right there, and of course the feeding tube because he's not able to feed at all. And after a few years, this is what he then becomes because now he wants to eat everything. And he is very obese and still has some very characteristic facial features, which we'll go over in a bit. But as he gets older, the obesity itself sort of doesn't completely resolve. He still has the central obesity, but the hunger isn't as much as it was in the childhood time. So based on that natural history itself, the pioneers of Prader-Willi syndrome, Dr. Driscoll from University of Florida and Dr. Cassidy from UCSF, they describe these nutritional phases of Prader-Willi syndrome. So the phase 0, which starts all the way back from prenatal to birth, with decreased baby movements, we talked about that, and they do tend to have lower birth weight than their siblings. The phase 1A from 0 to 9 months of age with hypotonia, which is how our neonate presented as well, and difficulty feeding and decreased appetite. Phase 1B from 9 to 25 months of age, there is improved feeding. So this is the time period when probably these kids are at their best. They are feeding better, their appetite is actually better, and they're growing pretty well. But right after around 2.1 years of age, some switch happens, and now their weight keeps increasing, even when there's not a lot of increase in the appetite already. But further on, as they progress to around 4 years of age, at this time now, they are extremely hyperphagic, and it's very hard to at that time to control the calories. So at this point, they need the dietitian support and a lot of psychosocial management. By phase 3, the 8 years to adulthood, these patients are still hyperphagic, and it's very hard for them to ever feel full to the extent. There is a very interesting documentary out there, Prader-Willi, also called Can't Stop Eating Syndrome. And in this documentary, there is these multiple adolescent individuals who won't stop eating to the extent that they want to eat their cat food and they want to eat the furniture. And of course, parents have to lock up the food cabinets, but it goes beyond even beyond that. Phase 4, thankfully, by adulthood, the appetite is no longer insatiable, and but they have their other issues that have already evolved since then. So the favorite part of genetics, which is learning about this morphology, and hopefully being able to identify these patients by just looking at them, would be looking at their face first and noticing that they definitely are, they tend to be microbrachycephalic, we would say that. So they do have a narrow bifrontal diameter and what we call bitemporal narrowing. The almond-shaped pelvic fissures are pretty famous, and so is the fish mouth parents. They do have a sort of narrow nasal bridge. There's a thin vermilion of the upper lip that you would notice in all these patients. It's sort of downturned corners of the mouth, frontal hair up sweep, more noticeable in this patient. The very interesting part about their hands and feet is, besides being small, they tend to be, if you plot them on growth percentiles, they're less than 5th percentile for the size of the hands and the feet. But they also tend to have these very straight ulnar borders, which is very characteristic for these patients. So clinical features, starting with hypotonia.
Sorry, but we're all looking at our hands right now.
So our older voters are not straight. There's a curve to all of us. Thankfully, yes.
Sorry, I'm sorry, say that again.
So we all definitely have a curve to our older voters.
Okay.
Yeah. So there's a sort of curve, but they're again said to be very straight. Yeah. So every time I get a referral for family, that's actually one of the first things I would look at. So characteristic features, we talked about hypotonia, but it's not just hypotonia. The entire presentation of this baby is actually very peculiar to the extent where this baby is sleeping a lot. There's of course the deep cry that we also noticed with our patient, very poor suck, poor reflective. So it's just overall a very weak-looking child. The developmental delay goes on to progress as they get older, intellectual disability. We say most of them are mild, so in the milder range about 60 to 70 of IQ, but about 20% of them can have moderate to severe intellectual disability as well. Hyperphagia, the characteristic can stop eating syndrome, food seeking, obesity, which does remain central. The underlying etiology for obesity is quite interesting, and it's still controversial, and people are still trying to understand why our kids are probably obese. So the theories go on with hypothalamic dysfunction, elevated levels of ghrelin, which is this appetite stimulant hormone produced from the stomach. But nothing is definite yet. We're still evaluating understanding this.
Can that be measured?
Yes, it can be measured, has been measured, and children with Prader-Willi syndrome are found to have more elevated levels. So behavior and psychiatric issues, temper tantrum, skin picking becomes quite a severe issue. The temper tantrums are typically associated with the food-seeking behavior, obsessive compulsive disorder, autism spectrum disorder, and ADHD. Hypogonadism starts noticed early on at birth with the genital hypoplasia in males with cryptorchidism, and 80 to 90% of them would have undescended testicles. But even females would have the labial hypoplasia, which is often missed in the menstrual period. Later on, they will have delayed and often incomplete puberty. Primary amenorrhea in about 56% of these women, and infertility later on is typically the short stature, also very characteristic. Growth hormone deficiency has been assessed and is well known for children with Prader-Willi syndrome. Average height for males is only about 155 and females about 148. There are other endocrine abnormalities as well, just sort of going on with the hypothalamic dysfunction theory. Central adrenal insufficiency is seen about 60%, hypothyroidism, so we always want to check their thyroid levels. With the central adrenal insufficiency, again, it's another controversial topic. There are no formal guidelines to evaluate for that, but we know that's it's a caution that we always have to address with these patients, that they can present with crises. Type 2 diabetes, as they get older, adults, about 25% of them will present with diabetes. Sleep abnormalities with the central and obstructive apnea, strabismus, and myopia, these ophthalmological issues, as well as dental issues, crowding, malocclusion. Skeletal issues remain for them as well. Hip dysplasia, scoliosis is pretty common, 40 to 80% of them. The other associations, seizures, may still be associated 10 to 20%. Hypopigmentation is an interesting one that some of these kids may be hypopigmented. Thick saliva, like we were talking about, the viscous thick saliva is very characteristic. Ulcers don't get any better with the skin pricking issue that they have. Altered temperature sensation, which even our child had early temperature instability. High pain threshold to the extent they don't mind the blood draws if you do them. Again, going on with the hypothalamic dysfunction. They tend to be great with jigsaw puzzles, so that's pretty amazing. Premature osteoporosis as they get older, so that remains a problem for adults. So talking about etiology, we know that majority of them are caused by the deletion syndrome here, which involves the 15q11.2 to q13. Typically, this a size of about 5 5 to 6 megabases. So about 65 to 70% would be the deletion. The maternal uniparental disomy comprises about 20 to 30% of the cases, and an imprinting defect or translocation itself, which disrupts this area, the critical Prader-Willi syndrome region, that would be about less than 1%, but it's well known. So the testing strategy for us, I apologize, the slide might not be very clear here, but we do like to do our baseline evaluation with the SNP array itself now can detect about 80 to 90% of the patients with Prader-Willi, because it will also not only will it look for the deletion in 70% of the cases, but it will also look for the uniparental disomy, which it did for our patient as well, as it identified the area of homozygosity. Methylation studies would be the more specific ones, and this would identify over 99% of patients with Prader-Willi. If you are still very suspicious clinically and none of these first two tests will come back positive, then you may want to think about imprinting defect, and that would be further repeat sequencing for imprinting defect mutation and deletion. So these are the common mechanisms with the Prader-Willi. We just talked about the Prader-Willi critical region right here. The common one is the deletion and the uniparental disomy there, and then some patients can still have imprinting defect as well. So might look like a complicated slide for people not routinely doing genetics, but this is just a demonstration of showing the area of the Prader-Willi. This is the Prader-Willi specific region itself. This right here is the Angelman syndrome region, which is the sister syndrome for Prader-Willi, as we call it. There's a whole imprinted region, and this is the non-imprinted region. The thing to remember here is that the most important gene so far implicated with Prader-Willi is the SNP, which is SNRPN gene, as well as the NDN gene. So these are the most important ones that we think are responsible for the presentation itself of Prader-Willi. And most of the deletions tend to be about the type 1 deletion, which is about 6 MB. And there are smaller ones too, the type 2 deletions, which tend to be about 5.2, 5.3 megabases. So it's interesting to know if the different mechanisms lead to different presentations of these patients. Well, there have been studies to find that out, and we have noticed that yes, with deletion, the patients tend to be more severe. There's more severe feeding issues and delays, intellectual disability. And the hyperpigmentation also is more commonly seen in patients with deletion, more common behavior issues and compulsive issues. With the uniparental disomy type, however, these patients tend to be post-term or term, like I think our patient was about 37 weeker. Facial features are less common. They do have a higher verbal IQ and milder behavior issues, but later on in life they tend to have more issues with psychosis and psychiatric abnormalities. So management for any child with Prader-Willi syndrome, first and foremost, we have to do it's more a management for the family itself than just for the patient. It's quite a complex and difficult diagnosis for the patient and the family who weren't expecting it while they were expected to have a normal newborn child. So family education and support is critical. Early intervention, at this point, that's our most important therapy for any genetic disorder. So early intervention evaluation as soon as possible. A lot of these patients do have to go through tube feeding, and a portion of them also undergo G-tube, like our patient did. But typically they do outgrow that, and after the next nutritional phase, they're able to feed appropriately, and in fact, much more than they should. So control of food and environment and regular exercise at that time becomes imperative. And typically we involve dietitians to assist with that. And growth hormone therapy, of course, as previously mentioned, FDA approved in 2000. And the indication is not necessarily the growth hormone deficiency in Prader-Willi, it's the diagnosis of Prader-Willi itself. So, so that's been a remarkable achievement for us. Management of transition from adolescence to adulthood. There are different group homes with experience in management of Prader-Willi. I found there was one in Illinois, Lutheran Illinois Center. and so the adults with Prader-Willi can actually have a more controlled environment experience in such homes. But of course, screening for psychiatric issues and skeletal issues as we get older. So, as we are all pediatricians here, I definitely want to bring this up that there are well laid down health supervision guidelines from AAP. So we all should be aware of that. But there are also Prader-Willi specific growth charts. So we don't expect the children with Prader-Willi to grow under the normal pediatric curve. So there are special growth charts from them, and the recent update in 2015. Annual TSH and free T4 reporting surveillance, so not just once, but we typically like to do it every year. X-rays for scoliosis. As they get older, we like to check for their bone density, so DEXA scans, and often they improve with vitamin D, calcium, and bisphosphonates. They do have a osteopenia. Annual behavior psychiatric evaluations and SSRIs are the most commonly used, and they benefit usually with that. Controversial treatment with testosterone and estrogen for hypogonadism, but we typically, of course, endocrine is a huge part of their management, so that's decided case-to-case basis. Skin pricking, interestingly, topiramate seems to be well effective for this problem. So growth hormone therapy, there have been different schools historically about the treatment of the use of growth hormone therapy in Prader-Willi syndrome. I'm a huge proponent. I definitely believe in growth hormone therapy. I trained with Dr. Philip Lee, who was one of the pioneers of growth hormone therapy for Prader-Willi. There have been some incidences of sudden death associated with growth hormone, but later on we found out that those were all actually related to some pre-existing cardiorespiratory issues that these children had. So, of course, we do want to start with a very well organized clinical evaluation with the endocrine ENT assessment, sleep studies before starting this. It can be started in infancy, so our infant, in fact, should have been referred to endocrine and hopefully should get that evaluation pretty soon as well, but at the time of diagnosis. It seems to benefit hugely, has changed what we call the natural history of Prader-Willi. So it normalizes the height. Within about 2 to 3 months of growth hormone treatment, we notice improvement in tone and the activity of the child itself. And as in older children, about 2 years of growth hormone therapy has drastically increased their height percentiles from less than 5th to about 50th percentile. So it's definitely very helpful in increasing the lean muscle mass, and that improves their tone and improves their overall outcome. The acquisition of gross motor and language skills apparently is also effective, and it does help with the overall developmental aspects of the patient. Some groups have reported some improvements in cognition and intellectual issues, but that still needs to be explored more. We're not exactly sure about that. So this is just showing the differences that we see in children with Prader-Willi who are treated with growth hormone versus the ones who are not. So you see a very striking difference here, of course. And these children look nothing like a Prader-Willi syndrome to you. It would be hard to even diagnose them with Prader-Willi, right? If they walk in our clinic. So yes, it is. It's hugely beneficial. So I would advise Prader-Willi syndrome endocrine referral. So besides growth hormone, there are some other new therapies that are now upcoming, and the Prader-Willi Syndrome Association has launched the oxytocin study, which is currently in phase 3 now. So oxytocin, as we know, we learned about it recently, the love hormone. It's found to be deficit in the paraventricular nuclei in brain and kids with Prader-Willi. It does decrease appetite and improves mood, so it's found to be beneficial for these children. So we'll see how this trial goes on. Carbetocin is another oxytocin receptor agonist, but it's receptor selective, so it seems to be probably more specific than oxytocin itself. There are some additional therapies out there, still investigational, but setmelanotide, which is a melanocortin receptor agonist, again involved in the food regulation pathways in brain seems to be helpful in improving the food-seeking behavior. Diazoxide, which has been used for a while, and now there's this new drug company that's pioneering this trial. The underlying basis is that it does actually hyperpolarize the hypothalamic neurons by affecting the ATP channels, and it may be useful for even children with Prader-Willi. So who knows? So these things are underway, and we'll find out more about them in future years. But we are pretty excited. So with the family education itself, we definitely when we meet these families, and as I did with this family as well, there was a lot of underlying sort of psychosocial issues too going on in these families. So we do like to not only discuss the diagnosis itself, the implications, but also provide resources that are out there. So there's Prader-Willi Research Foundation and Prader-Willi Syndrome Association that we like to mention. And they have wonderful parent guides that we like to share with the families. So hopefully, I feel this is not a one-time education, but it's going to be a lifelong education for them. So we like to do that at each visit. So these are again patients with Prader-Willi, which you wouldn't necessarily think have Prader-Willi syndrome, but markedly improved with growth hormone therapies. All right.
Question? Is there a genetic mechanism that the growth hormone has to do with the deletion itself, the components of the deletion?
No.
Some kind of secondary thing.
So the theory is that it just affects the hypothalamic function itself, and it's not just the growth hormone, but also actually all the other hormones there, including the FSH, LH, with the hypogonadism, but also even the adrenal function. We were talking about the central adrenal insufficiency and the thyroid function as well. So it seems to be much more generalized hypothalamic dysfunction.
Since I feel like now more and more of the moms that I see in normal nursery get the cell-free DNA tests for various trisomy kinds of things and all that.
Yeah.
Is there any prenatal diagnostic testing coming that you think will be able to pick up this sort of stuff?
Yeah, prenatal testing, if the mom were to get an amniocentesis, they will be able to diagnose this right away.
Sure.
But not a screening method yet. So we don't have a screening
There are
method.
some lab work for the prenatal that cell-free DNA that include the 15 to 1.1 deletion.
Oh, really?
Yeah,
Some
deletion.
lab work.
But that's still in the early stages of the gene being used.
Thank you.
Thank you.